This lecture is on diuretics. Diuretics are used to lower blood pressure and decrease edema. Give diuretics in the morning. This helps to reduce falls and increase adherence to the regimen. If a patient who is on diuretics has a weight loss or gain of greater than 2 pounds, you want to report this to the doctor. So this happens inside of the kidney. There's all sorts of exchange of ions and fluid that goes in and out, and urine that gets made in the kidney. And the different spots that the meds we talk about affect the kidney have to do with what type of electrolytes will be lost. So we look over here, and if your med actually affects just that collecting duct, it's potassium sparing. But if your med hits anything pretty much before that collecting duct, you are not potassium sparing. In fact, you're potassium losing. And especially the loop diuretics, these things are highly affected and are a huge risk for hypokalemia. So when we look at the type of diuretics, we look at a loop diuretic, an osmotic diuretic, a carbonic anhydrase inhibitor, a potassium-sparing diuretic, and a thiazide. Thiazide and thiazide-like diuretics include hydrochlorothiazide. Okay. Also, metolazone is in this category. The really big thing with this is hypokalemia. This is the thing that'll kill you the fastest. So if someone has a low potassium, you really want to be watching that, and you're going to hold the medication like metolazone or Diaryl or hydrochlorothiazide until you get a plan from the doc, which might be potassium supplementation. Potassium supplementation may need to come before you actually give a diuretic. Potassium supplementation needs to be done with meals. People need to know they can't chew it, and obviously don't give potassium supplements when the potassium's above 5, right? Well, on the converse, don't give diuretics that are going to make a person lose potassium if their potassium is under 3.5. So if you go to your 2 charts, different charts will tell you 3.5 to 5 is normal for potassium. Some charts will tell you 3.5 to 5.5. Okay? Loop diuretics. These are things like furosemide or Lasix and bumetanide, like Bumex. Again, the most suspicious thing in using a loop diuretic is hypokalemia. You really want to be watching that potassium. You really want to be making sure that you never give a loop diuretic if that potassium is less than 3.5 without some guidance from the doc as to how to replace that potassium. Osmotic diuretics. I think of SpongeBob when I think of osmotic diuretics because mannitol is a diuretic that is an osmotic diuretic. They can be used to decrease ICP, and that's usually what they're used for, is decreasing intracranial pressure. It says here we can use it for decreasing intraocular pressure and preventing kidney failure. But usually these osmotic diuretics are used for decreasing intracranial pressure. Side effects, really watch those fluids and electrolytes. If you go back to the chart, you'll see that mannitol affects every portion of the renal tubule. And so electrolytes can be all over the map. Risks are actually pulmonary edema, nausea, vomiting, tachycardia, and acidosis. And I'll tell you why that pulmonary edema fits into there is because these osmotic diuretics go to places like the brain and sponge up all of that intravascular fluid and then wring it out at the kidneys. Now, when they wring it out at the kidneys, if those kidneys aren't working, you know, the fluid can go back into the body. So it is contraindicated in heart and renal failure. Beware the crystallization of mannitol. So be looking at your product before you use it, but also it's not compatible with a whole lot of things, which means that you can't run it through the same tubing. And so sometimes if you run things that are incompatible with each other, they will form crystals. And that's not good because you don't want to be putting crystal particles into your patient. Carbonic anhydrase inhibitors, examples would be acetylamide, dichlorphenamide, ethoxazolamide, and methazolamide. These decrease intraocular pressure in chronic glaucoma. So watch those fluids and electrolytes again. Watch for metabolic acidosis, nausea, vomiting, anorexia, confusion, orthostatic hypotension, crystalluria, hemolytic anemia, and kidney stones. This does not sound like a fun one, does it? Potassium-sparing diuretics are really important for some patients. And so we can use these for people who are losing large amounts of potassium when they're taking the other types of diuretics. But we really need to watch these because these can have the opposite effect. And they can actually make the potassium go too high. So one of the side effects is hyperkalemia. And it gets worse if it's given with an ACE inhibitor, so we want to be really careful with this. Examples of potassium-sparing diuretics are spironolactone, aldactone, amiloride or imidamor, triamterene or diarenium. And what we want to say about spironolactone, because that's the one that you're actually going to see, aldactone, that's the one you're really going to see more often than the others. It's an aldosterone inhibiting diuretic. So since this one can result in hyperkalemia in a high potassium, you want to avoid salt substitutes like Mrs. Dash. These things can have potassium utilized instead of sodium to add the flavor, and that is problematic because it can result in hyperkalemia.